your guys' benefit, I'm going to just leave you unmuted.
Okay.
And so please feel free to interrupt me at any time. So what I'm going to do is spend the first few minutes kind of talking about what the clinic's goal is, who should come. I'm going to briefly go over the Homeless System Evaluator tool that you'll want to, that the HMIS folks are probably on the line to learn a little bit more about. And that, we'll talk a little bit more about that, the consumer surveys and leader and provider surveys that you'll be distributing. And then we'll talk about some next steps and what kind of information that we'll need from you. So that's the agenda.
Sounds great.
And if there are questions that you guys have, I am actually recording this webinar. So you know, you can send it to folks, but also I will share it with Kay. So if there's things that I can't answer, or you know, just information that we share that's, you know, you want to be captured, I just want to let you know that I'm recording it, so she'll be able to watch it when she's feeling better.
All right. Perfect.
So first I want to tell you sort of who I am and sort of who Kay is and how we work together. We both work for the Center for Capacity Building at the Alliance, which is a mighty team of 3. And we do training and technical assistance. So how interacting with us works, just so that it's clear, Kay is your main point of contact for pretty much any question that you have regarding the System Design Clinic. You can also include me on things. Kay, in particular, has some work travel coming up, so if you really need a question answered and you can't get to her right away, you're welcome to contact me as well. But just make sure that, you know, at the very least, Kay is on everything and that she'll be your main point of contact. The only reason she's not on the line today, as we were talking about earlier, but I don't think our HMIS folks know, is because Kay is not feeling well. So I also do system design clinics, but I won't be doing your system design clinic. But I'm happy to answer any questions. Kay will be your main point of contact. So I just want to make sure that's not confusing.
Great, thank you.
Okay. Let's see. All right. What is a system design clinic? So this didn't used to stand for something, SDC, but we've decided that just to help you understand what a system design clinic is and what the goals are, we've made SDC stand for the following things. So solutions, strategies, and resource allocation and homelessness, design for best practice crisis response system, and the critical role of governance to implement best practices. This is the kind of crux of what we're hoping to do with the clinic. So the clinic is 1.5 days long. The first day includes key stakeholders that represent your entire continuum of care. You will have to identify the key stakeholders in your community that you'll want to invite, and I will share with you just a list of sort of the folks that we tend to suggest. So with this critical group of stakeholders on the first day, you're going to take a look at what's working and not working in your current system. We're going to talk about best practices that we've seen working all across the country. We're going to evaluate strategies that you can change or improve on. So what is working, what's not working, what do we want to sort of look at changing about our system? And you're going to create your own plan to improve your system. So this includes interactive activities, some presentation, and a lot of discussion and planning around the folks who are in the room.
Great.
The second day is just for your Continuum of Care Governance Board or Decision-Making Committee. And we can talk a little bit more about who that is if you're not sure what that means exactly. But this is the group within your larger Continuum of Care that carries out the work of the COC, including ranking the Continuum of Care application.
Right.
So this is a much smaller group of folks because they're really going to do a lot of planning. And on the second day, as I also mentioned, is a half day. So their goal is to take everything that we talked about and everything that we learned and some of the discussion around the first day and create some real action steps to move forward.
Perfect.
All right, so who should come? Did you guys invite people yet to the clinic?
We've done some save the dates. We're in the middle of or wrapping up appointing some new members to our board because we had sort of an inactive board, or partially inactive, so getting some active members and restructuring because we had a lot more provider types than, policy people that had influence in the community, so we've been really working around that. So we've been doing a lot of save the dates kind of stuff with some of those key stakeholders, but we're finalizing our list so that we can get some formal invites, like, we really mean you, please come. And
gotcha.
And to try to, in the event that someone can't make it, to be able to identify somebody else or, work on that. So we know if we want the right stakeholders there, they have busy calendars, and we got to get it on there now.
Perfect. That's great. I'm really happy to hear that you started that already. And your clinic, I think, is about 35 people, so that's not a ton of folks from the beginning. So it's just, I think the main point is that this clinic isn't really for the frontline case managers kind of folks. This is for the sort of higher level governance folks who are decision makers and can, really make decisions if they need to day of about, yes, this is something that we need to work together to change. That doesn't mean that people with lived experience of homelessness or frontline service providers can't come, but the conversation and the presentation is really geared towards people with a higher level understanding of the homelessness assistance system and people who can make decisions. So depending on what your system looks like, this list up on the slide are the kinds of folks that we typically see, and I imagine that this is somewhat reflective of what your list looks like.
Yeah.
Okay. So then on day 2, only the folks, the governance, quote unquote, continuum of care governance folks come back. So do you have an idea of who that smaller group is?
Yeah, it would be our continuum of care board. And one thing I wanted to ask, should that include, or does that frequently include chairs of, so we have, a board, and then we have committee chairs that aren't necessarily appointed board members, or should it just include the board? So like we have a committee, a housing committee, some of those. And I don't know if that's important, or we can just disseminate that information as we need to.
I think that's ultimately your decision. I think your decision-making factors here are A, you don't want it to be too many people that you can't get any actual planning done, and B, like how active are those committees? Like, are they really? I sit on a local continuum of care board, and there is one particular committee that that makes all of the decisions pretty much in a very strange way. So like the person who's on that committee would be very important, but sometimes the committees are really just not involved. For example, if you have like a community outreach committee that just talks about like ways to raise awareness about homelessness, maybe that's not as important as the the ranking committee. So just yeah. But yeah, if you want to sort of shoot us a list of like, hey, what do you think of these kinds of stakeholders? We're happy to to like provide input, but ultimately that's up to you.
Okay. So Anna, this is Christy. So about how many people do you like to see on day 2? I mean, if we've got the 35-ish people coming on day 1.
The board is like 11.
Maybe.
Okay.
Maybe. Yeah. I mean,
yeah, I'd say like 15.
15.
Okay. Yeah.
So like,
I mean,
give
11 is fine. 15.
Okay.
Yeah.
Okay.
But that's not hard and fast. It's like I said.
Right. Ish.
Okay.
Yep. Ish. Okay. Great. So preparing for the clinic. So what has to happen before the clinic? Because not only is each community unique, but the clinic works so much better when we have local data to present. It's just one of the factors that really makes or breaks the success of this clinic. So there's sort of two parts to the work that we ask you to do as part of this clinic. Okay. The first I'm going to talk about is the Home System Evaluator tool. So this is a tool that you put in your local data, and it provides system-level outcomes that help us analyze your the performance of your system on a couple of factors. Okay. So I'm going to pull that up now. Have you guys, HMIX folks, have you looked at this evaluator yet?
I took a brief look at it yesterday, but I didn't delve deep.
Okay, great. That's totally fine. So can you guys see, let's see, audience view. Are you guys seeing the, oh, perfect.
Yeah,
okay.
I can see the pin.
So there's a couple ways to find the evaluator. It's on your next steps document. It's in your Dropbox that we shared with you. You can also just go to our website and type in evaluator, and it's the first result. So it's really easy to find. So this is the evaluator. So I'm going to just briefly go through an overview of it, okay. And then if you guys have more detailed questions, please, you know, we've never had a clinic where someone really just 100% does this on their own and never asks us a single question. So we're expecting to, to be a resource for you guys going forward as you complete it. So. Just first of all, the kinds of data you'll need to do the tool, data from your last 3 point-in-time counts, your AHAR reports, housing inventory charts, and HMIS data. Okay. So let's see. So some of the things that it looks at just broadly are how quickly are people exiting homelessness from your system? Mm-hmm. Are your interventions cost effective? And the performance of different intervention types. We're really not going to look at shelter A versus shelter B. We're looking at shelter, transitional housing, emergency, I said that, rapid rehousing and permanent supportive housing as intervention types, and how they're comparing with each other, and like what kind of outcomes you're getting based off of your investments, right? So it's system level data analysis. Well, and I'll talk about this. You can enter program level performance and see that as well, but we're not going to present that at the clinic.
Oh, great.
So can you guys see the workbook okay on my screen here?
Yeah.
Yeah.
Okay. So at the bottom, you'll notice that there are green tabs and there are yellow tabs. The green tabs are not for you to enter any information into. These first two tabs are just graphs that will automatically populate. Okay. The yellow tabs are data entry tabs. And so like there are yellow and green tabs, there are yellow and green cells within the evaluator. So the yellow cells you enter data into, and the green cells are automatically calculated. So you don't need to enter any data into them.
Okay.
So the first tab here is our population summary tab. And so my first question for you is, do you have your 2015 point-in-time count data?
Do we have it? Yes.
Yes.
Okay,
I don't have it
great.
in front of me, but yes. We
have no, that's fine. That's fine. No, that's great.
Yeah, I know because some communities still haven't released it or it's not finalized.
Exactly.
Yeah.
The dates on the evaluator and on the graphs are 2015, 2014, and 2013, and we always want you to enter in your most recent data. But if you don't have 2015 data, I would update the tool for you so that you could enter in 14, 13, and 12. But we have 2015. That's great. We should definitely use the most recent data.
Okay.
So this first tab. This is just where you enter some really basic information from your AHAR and your point-in-time count. And so our second tabs, 2 and 3, you will be entering data into one or the other of these tabs. So you'll need to decide whether you want to enter program level data on performance or systems level data on performance. It's really whichever one is easiest for you. If you have the ability to do systems level data from HMIS, that's great. Some of the reasons you might choose to do the program level data is, say you have a program like a very large mission that makes up a huge part of your continuum of care that's not in HMIS, but you managed to get data from it, you might want to enter that in here.
Oh, okay.
So it's really up to you which one you use, but you enter in data to one or the other. One other thing I will add is that we have not updated the evaluator based off of the new data standards. So what that means is in some of the instructions, it'll tell you pull things from 14, 15, and 16, and now that's 17, 18, and 19. So Kay has figured out what the new instructions should be. We haven't updated the evaluator yet because she just did this like yesterday, I think. But she is going to email the HMIS folks if we can get, I'm not sure if she has your contact information, but
we can get it to her, yeah.
Yeah, and then she'll email you the new instructions for where to pull that. And you might not need that, honestly, but it's helpful for it to be accurate, right? So just a caveat there. Let's see, what else do I want to say about this tab? So if you decide to enter program level performance data, that information will automatically be aggregated into the tab 2, right? So this is why you do one or the other. So if you if you do program level data, it'll roll it up to performance level data, and then that will impact tab 4, cost data. So do tab 2 or 3 before doing tab 4, right? You want to go through these sequentially if possible. Does that make sense?
Yeah.
Okay, great. So cost estimating. This is there are instructions on tab 5 for cost estimating if you don't have great cost data. But I want to be clear, the best possible cost data that you can enter here is your entire program budgets, not just one funding source, right? We're trying to get an accurate picture of what an entire program costs. So this might even, and the APR includes match and as well, but that's still only, oftentimes, that's only a piece. So how do you do that? Oftentimes we find, it's calling them, spending a little time on the phone and asking them. So if you cannot get that data, there are tips for estimating it based off of what you can find out, but it's going to be much more impactful if you have the time to call your providers and beg and plead for their program budgets. Okay, so the next tab I want to talk about, and this tab 6 is green, you'll see, so we don't do anything with that. It just rolls up your cost and performance into a summary so that we can make graphs out of it. Tab 7, system entry analysis. So this evaluator tool now is a few years old, and so this was designed around HPRP, prevention information. But what we're finding, and the reason it's still here, is because oftentimes people don't have data on prevention in terms of where people are coming from. So it's really helpful to, if you have data on prevention in your community and people's, where people are coming from, we want something that's more recent if possible, but if HPRP is the best that you have, then that's what you should enter. Okay, so that's my quick overview of the evaluator tool. Do you have any questions? I know it's a lot, but do you have any questions right now before we talk about the surveys?
I don't think I have any questions right now. I don't know if the HMIS team does, and I know they have a better understanding of what the data looks like in the system, so they may, but probably we'll have questions as we start doing it, is my guess.
Perfect. Perfect.
Tish, you guys have any questions?
No, we don't have any questions right now.
Okay.
Great.
Not yet.
Yeah.
Thank you. And I just want to say that the reason we ask for the HMIS folks and the leadership folks both to be on this is that it's so much better when you understand why you're spending all this time entering data into this, so we're all on the same page. And now leadership folks who are asking them to enter data into it, you can understand that you can appreciate all the hard work that they're going to do for this. So, but yes, if you have more questions, please feel free to contact Kay or I.
Okay.
So the other thing that we're asking you to do is administer 3 different surveys: community leader, provider surveys, and consumer surveys. So I don't believe I've gotten any responses.
No.
Okay, great. So you haven't sent them out. Okay,
Yeah,
so let's talk about
until the webinar, yeah.
Perfect. So let's talk about who they should go to. So the first survey is for community leaders. And the community leader, all 3 of these surveys have similar questions. They're not the same sets of questions. The provider survey and leader survey are more similar than the consumer survey. So people should probably only fill out 1. So sometimes people can fall into multiple buckets, but you might want to segment your list that you distribute these surveys to so that people only get one or the other. So who should fill out the leader survey? These are the folks that are coming to your clinic most likely. Your continuum of care leads, ESG administrators, executive directors of homeless service organizations, foundations, funders. This is also good if there are providers who, or community leaders or partners who can't make it to the clinic, but this gives them the opportunity to have input into it.
Okay.
The provider survey is also similarly, not a lot of providers. You probably have a lot more people who fall into this bucket than can come to the clinic. So this is their chance to be heard. And so this is the frontline staff, the program managers, case managers, employment specialists, housing locators, HMIS staff, direct service staff should all fill this out. So we'll probably have the most provider surveys out of any of these 3.
And one question about provider surveys. The explanation you gave is great. We did have a question about, we have a lot of not formal but volunteer and faith-based people in the community that aren't providers in the way that we would normally define providers, but they are providing some level of service to people at times. Is there a place where, do we lump them into the providers? Do we not?
I would recommend taking a look at the survey and deciding. I would probably include them because oftentimes those folks play a really big role not only in how the system operates, but also the messages about our community that we're communicating that make our system work. So for example, there is a question on the provider survey about whether or not your community has a coordinated assessment system. Someone who's not super involved in the homelessness field, but maybe is a member of a church outreach team or a homeless hospitality kind of church thing. I hope you guys know what I mean. But anyway, might not know whether or not you have a coordinated assessment, but I think that that's an important thing to know, to address. Because if they're going to be, a part of this system, they should know how coordinated assessment works and how to connect people to it, and that, that this is a community initiative that they that we want them to support and be a part of, and that have their voices heard. So even though they may not understand the nuances of every single question, I think that their input is probably important.
Okay. Agreed. Just wanted to make sure. Thank you.
Sure. So the final survey is for people who are currently or have formerly experienced homelessness. So just to be clear, there's no evaluation of programs in this survey. It's very general information about the experience of homelessness in your community. So for example, we're asking things like, how easy was it for you to access services when you became homeless? What could have prevented you from becoming homeless? Very general things. It's also anonymous, so we won't know who they are when they complete it, which I think is very important to note when you distribute it. So the easiest way for you to distribute the consumer survey is to have your providers, if there's a computer that people can use, to have the survey up there and allow people to sit down and complete it. If that's not the case, we have a paper copy of the survey, which is a PDF, in your Dropbox, and you can have your providers print this out, although someone will need to go back in and enter that into the survey. So it's a little more time intensive. But the consumer surveys are very, very powerful, and they're really important. And we have another clinic that we're doing in early September, and they have managed to get something like 100 consumer surveys, which is pretty.
Well, and Kay said that, and she said she was going to ask them what they were doing to help.
Oh yeah, I'll follow up with her on that.
To give us any tips on how they've been so successful in getting those surveys completed.
I think they're also a really large community, so there's
okay. Well, that would make a big difference too.
But here's the other thing is that, you know, when we have a clinic and we have 5 consumer surveys, we almost can't share that, right? So you don't need to have 100. If you have 100, that's awesome. But we really want to have enough that we can have the consumer voice be heard in this clinic. So yeah, so those are the surveys. Any questions about that? You guys have the links in your next steps document.
Yeah. So I do have a question. This is Christy. Anna, so is there a function that prevents a person from submitting multiple responses, or do we care?
In the leader and provider surveys, we've turned that off in the consumer survey.
Okay.
Oh, I'm sorry. I wonder if I answered the right question. So not for, you could fill, if you had links to both the leader and provider and consumer survey, you could fill all 3 of those out. But you could fill out multiple leader surveys.
Right. So can a consumer fill out multiple surveys?
Yes.
Multiple times, answering?
Yep.
Okay.
Yeah. So we can change that. But the reason we do that is because if folks are going to share a computer in like a computer room in a shelter or what have you, that
so
multiple people will fill it out. So
right.
Okay.
It's
great.
tied to the IP address. Is how it's
for
controlled?
The leader and provider surveys. The consumer survey doesn't collect IP addresses because it's anonymous.
Okay. Perfect.
Yep.
All right.
Because
I'm thinking we'll probably use our one-stops and maybe public libraries and some of the other places to try and really encourage consumer survey responses. And so a lot of people are going to be doing the survey, a lot of different people on the same machine sort of thing.
I would also encourage you to try and reach out to maybe permanent supportive housing providers, people who are formerly homeless as well.
Right.
Perfect. All right. So other stuff you can send us. This is in your next steps document as well, and this is really helpful for us to have. But for some of these things, if you have a 10-year plan to end homelessness, for example, that isn't an active document, that isn't really being used, we don't need to see that. We want to see documents that are really guiding your planning process, that you feel like are representative of the way that your system works, so that we can have a better understanding of your continuum.
Okay.
So there might be other things that aren't on this list. For example, if you have worked with another technical assistance group that's written an analysis of different parts of your system or what have you, those are really helpful for us to see. Anything that can help us understand what's going on in your community. And the way you share this with us is Kay has shared a Dropbox link with you. If you're, it sounds like you guys might be familiar with Dropbox. It's just a way to share documents.
Right.
So sometimes, particularly government folks have firewalls that prevent them from using Dropbox. And if that's the case, that's fine. You can email documents to Kay. But if you can upload them to Dropbox, that's really helpful.
Yeah. And it has some protection here, but we can use it web-based, and it's no problem. So
perfect. Okay. So the logistics. Your clinic is October 14th and 15th, if you did not know that. It's the first day is 9 a.m. to 4:30. The second day is 9 to 12:30.
No.
We recommend having registration be a little earlier than that so folks are ready to go. The room setup here, we have our very first activity of the day is a game that requires rounds of 7 to 8. If you don't have rounds, if they're not 7 to 8, we can work with it, but that's our preferred setup for the first half of the day at least. Projector and screen, roving microphone, flip chart with stand. We suggest that you give people lunch on site because it makes it faster, but if you can't do that, that's okay. It's just important to let us know because it will impact the length of time that we allow for lunch in our agenda. And also, depending on where your clinic is, sometimes people have to travel a little bit farther to go find lunch options. And so we'll just let us know kind of what the situation is so that we can build enough time.
And I don't want them leaving. Nope.
Right, and not coming back.
There. I'm holding the door.
Yep.
No stepping out.
That's the other reason.
We have work to do.
Perfect. Any questions about that stuff?
No, that's good.
Okay. All right, so next steps. Sounds like you have your invitation list. You're working on finalizing it, so that's good. You sent out a save the date. So 1 and 2, check. Start working on your evaluator tool as soon as possible. Develop a mailing list for the surveys. Send out links to the survey lists, and begin uploading those documents to Dropbox. And so the date that we included as your deadline, quote unquote, for these things is September 8th. I know that's like really soon now, and you guys were waiting for the webinar to get a lot of this stuff started, which is totally fine.
That's okay.
Just make sure if you feel that you're not going to make the deadline on some things that you're communicating with Kay about that so that she can sort of work in her schedule. The earlier that you have the stuff to us, the better your clinic is going to be, because the more we'll be able to analyze it and understand how your community works. So just make sure you let Kay know how that's going. Let's see, what else? Surveys completed. Yeah, I think that's it.
All right.
So any other thoughts or questions for me?
I can't think of anything right now. All I'm thinking about is that I have work to do.
So can you all hear me?
Okay, you're on the line.
Hey. Hi,
So
Kay.
I have been listening in. Hi, I've been listening in. I think Anna covered everything, but I just wanted to say that really excited to work with you. I will work on getting that those updated instructions out, and it's basically where people exit to for your HMIS folks on the evaluator tool. They added some new destinations in the most recent update that our instructions don't include, so I've assigned all of those destinations to one of our, one of the places that you need to enter them into, so I will get that out to you as well. But I think Anna covered everything. If you would have seen me, I was shaking my head yes many times. He was answering your questions. So so thanks for being on the call, and I'm going to jump off now, but looking forward to working with you. Thanks.
Bye.
Okay, thanks everybody.
All right,
thank you, Anna. Thanks, HMIS crew. Thank you.
Exactly.
We'll talk soon, I'm sure.